Dear Pure Urology viewers, good evening one and all. Today topic is on PCNL. As you all know, PCNL is one surgery which is commonly performed. Most common way of doing it is prone PCNL. Even though recent times supine PCNL has come, normally in the recent past also we have discussed about the various angles, triangularization, bullseye. That means you are rotating the C-arm either cranial or caudal or towards you or away from you in 4 angles. What you see is in one you will see the medial lateral, another one you see anterior posterior, that is nothing but depth. But if you see seniors and some of the experienced surgeons, they will do puncture in 0 degree. They will assess the depth depending on the patient body habitus with clinical experience. At the same time, they will see the movements of the kidney. They will assess properly the calyx where it is located. They will see the loss of resistance, all these things. This is so-called monoplanar technique. Basically, it is not compulsory that you have to do in monoplanar for the audience, but it is a technique where individually experienced surgeons or some skilled surgeons will do with monoplanar. What is the trick in monoplanar? How they will be able to assess the depth? Let us listen from Dr. Harshawardhan, who is a friend of mine from the Ahmednagar and a very enthusiastic junior who has learned PCNL in short period of time and has become the national faculty demonstrating in various conferences. Dr. Harshawardhan, I will introduce. I will share my screen. I will introduce first his CV and then I will hand over the program. Harshawardhan, good evening. Thank you for accepting the invitation.
Yes, thank you, sir. Thank you. It's an honor for me.
I'm happy to share again your surgical skills in pure urology. So today's topic is demonstration of monoplanar puncture technique in PCNL by Dr. Harshawardhan. Dr. Harshawardhan Tanwar is Director Consultant Urologist at Satalkar Lotus Super Speciality Hospital, Ahmednagar, Maharashtra. Head of PCNL Training Institute at SLS Hospital. Convener of Urolithiasis Section of USI 2022. Recipient of Best Resident Doctor Award, Seth AS Medical College at KEM Hospital, Mumbai. Demonstrated PCNL puncture techniques as faculty at ECCON Kochi 2020. Participated in debate with stalwarts of Indian Urology at 2018 PERCON. Presented a talk on use of flexible guided system in PCNL at Advancement in Endourology Conference in 2019. Faculty and moderator for Dr. Oliver Trax talk at RIRS versus PCNL Conference Hyderabad 2019. And he also did live PCNL surgery at prone versus supine PCNL Conference organized by Preeti Hospital team by me at Hyderabad in March 2022, where he could do the 1.5 centimeter within 10 to 12 minutes. Operated live RIRS surgery at Stone Conclave Conference, Bilaspur in 2022. He has 25 international PubMed indexed publications. Very good CV in the beginning part of the career. Everybody loves to have this type of CV. And with this introduction, without wasting much time, let us listen from him the technique of monoplanar PCNL puncture in prone position. Thank you, Harshawardhan. Over to you again.
Just a minute, sir.
Yeah, no problem. Take your own time.
Yes, sir.
Because the rains on the both the sides, there may be some communication problem. Please bear with us. Hopefully, everything goes well. In Hyderabad, it is raining.
Okay. Are the slides visible, sir?
Now go to the first slide. It is in the last slide I was seeing.
Okay. So is the first slide monoplanar puncture
No,
PCNL?
no, now I am not seeing anything. Again, close and reshare. While doing reshare, you go to the first slide and then reshare.
Fine, sir.
Go to the first slide in the before you share.
Yes, sir. Is it visible now?
Yeah, it is visible.
Hello.
Enlarge the screen. Little, yeah, enlarge the screen.
Okay, it is enlarged, sir. It is full screen now.
No, it is not. I think it is taking time to. It is not enlarged as of now. Yeah, I think it's taking time. Don't worry. It
Okay,
is giving
fine.
pause of reshare. Yeah, it is enlarged. Okay, go ahead.
It is visible now?
Yes, yes.
Okay, fine. So at the outset, I want to thank Preeti Urology team and Dr. Chandramohan sir for inviting me on the Pure Urology webinar programs. So today I will be presenting the monoplanar technique of PCNL puncture. So what is PCNL? PCNL is a game of judgments. It is the surgery of urology where you need a lot of judgment, a lot of calculations, a lot of depth perceptions, because it's a 2D image what we are seeing on the Siam films, but we have to play the game in the 3D environment. So before doing a PCNL, there should be a roadmap which should be very clear in the mind of the operating surgeon, because a good puncture is the key to success in PCNL. If you take a good puncture, 80% of the job in PCNL is done. If your puncture is not good enough, then you will be in trouble. So till date, there is no puncture technique ideal in PCNL. You take bullseye, you take triangulations, there are many mathematical calculations in doing the punctures in PCNL. But what should be our aim? Our aim should be safety first. You do any technique, but it should be good for the kidney, good for the patient, and you should clear all the stones. That should be the end point of PCNL surgery, without causing much damage to the renal parenchyma and less bleeding and no damage to the vital structures. So there are different techniques in doing PCNL. One is supine, other is prone. Today, let's talk about the prone PCNLs. In prone also, there are various techniques, as I have already told, that there is a bullseye, triangulation, hybrid. But here you have to move the Siam. Here the depth perception, the angle of your needle is calculated according to the movements of the Siam in 30 degrees crinocaudal or towards the surgeon, away from the surgeon. So there is a lot of jugglery need to be done with the Siam in doing this technique. What is a monoplanar technique? Monoplanar technique, there is no movement, there is a no touch technique to the Siam. You don't have to move the Siam, you have to calculate everything in your mind. What is an ideal access technique? The first point, there are two factors, anatomical factors we will look first. It should be from the posterolateral position. It should be through the renal parenchyma towards the center of the calyx posterolaterally, towards the center of the renal pelvis. Next, it should be less time consuming. There should be less fluoroscopy time and exposure, as it is hazardous. Less torque while maneuvering the nephroscope. This is a very important point, because even though you get a puncture nicely, you can see nice fluid coming out, but if the torque is there, you will hardly be able to move your scope inside the collecting system. So the torque should also be less while the movement of the scope is there inside the kidney. It should have minimal complications. Maximum stone load clearance should be there. Easily reproducible and versatile, and small learning curve. So what is monoplanar technique? In monoplanar access technique, that is different from other methods in that it uses only fluoroscopic projections maintained on a vertical plane You don't have to move the C-arm 30 degrees or anyway, it is the fixed C-arm technique. The C-arm is fixed in 0 degree. Angulation of the IP needle from the skin surface to the desired calyx is the key point. Also, calculation of the depth from skin to desired calyx. Highlights of monoplanar technique are angle of orientation and depth of perception, depth perception. So technique does matter because with monoplanar, you can go in the kidney in a very less time. There are less radiations, less complications, easy learning, and comparably good stone-free rates and good maneuverability inside the kidney. It's a short video. I will try to tell that with biplanar, triangulation, everything, these are very good techniques. I don't want to go into discussion in the same, but some techniques you can develop on your own because every guideline has some differences. There are some new techniques which we can do and we can come up with good results. So here I am showing a monoplanar man sitting besides the persons who are doing all the hybrid, biplanar and triangulation technique, and within few seconds he comes out with the fish. So this is the monoplanar technique. It is very easily reproducible. I won't go into the details, but here I want to show that in a biplanar technique, you can see the radiation exposure. It's a bullseye technique I am doing in this case. When we are doing bullseye,
using the bullseye
there is a
technique,
lot of exposure, radiation exposure towards the surgeon's hand.
In 30 degrees.
This is avoided in monoplanar technique. I'm going to show you many videos. Here I'm purposefully showing that while we rotate the C-arm in 30 degrees, there is exposure towards the exposure of radiation towards the hand. Aim is safety first. So this is a PCNL case which I did in monoplanar technique. You can see easily that the proximal ureter is nicely seen. I can roam around the kidney. That is maneuverability in monoplanar access is also as good as that in triangulation technique. So this is the superior calyx. I am trying to show. The puncture is from the lower pole. I come out.
This is the inferior calyx.
Go in the renal pelvis. The proximal ureter. So this is how we move inside the kidney. It is also versatile. Monoplanar technique can be used for multiple punctures also. These are the some cases which I want to show. In the first case, it's a completely superior calyceal stone with a very narrow infundibulum. In the same case, we have done monoplanar PCNL with very good results. Again, with the second case with a very narrow infundibulum, again done in the monoplanar technique. And the third case is multiple renal stones, multiple calyceal stones with a big pelvic stone. In this case also, we were able to do monoplanar punctures and clear all the stones. See, in this picture, it is clearly seen that we have taken 3 dilatations, 3 punctures are done to clear the stone. These were done all in monoplanar technique.
You can see this was the middle calyceal puncture.
Middle calyceal, inferior calyceal, one more diverticular puncture was taken. And after clearing all the stones with monoplanar technique, easily without any blood loss, we are able to take out all the
dilators now.
Amplas sheets.
Thank you.
So now let us come to the live video demonstration. It's a semi-live video demonstration of some cases what we have done in monoplanar technique. With this video, I will try to tell you what is the technique of puncturing the kidney in a monoplanar manner.
Showing the demonstration of the kidney.
So this is a RGP picture. Slowly the system has been filled with contrast. You can see a pelvic stone with
now on the surface
inferior calyceal with the inferior calyx dilated. It's a 7-year-old boy.
Moving the C-arm, I will be directing my needle 30 degree to the skin surface.
So the first step is to adjust your needle 30 degrees towards the skin surface, towards the desired calyx. So I am adjusting my needle 30 degrees towards the desired calyx. The skin and the calyxial depth appreciation has been done.
Marked my puncture site.
So
and with the needle orienting 30 degree to the skin surface.
30 degree orientation of the needle to the skin surface has been done. Now I'll be targeting the desired calyx. Slowly I will move towards the desired calyx with jerky movements to feel the kidney.
My needle to the cup of the calyx.
You can see that there is no exposure of radiations towards to the hand of the operating surgeon. So with slow and gentle jerky movements, I am trying to feel the kidney. The Siam is in vertical position. It has not changed its position.
On the surface view, please.
So there is extravasation of the contrast. That means we have entered the kidney.
So
on the very first go, we are able to get a clear aspirate.
So without moving the Siam, we have taken this puncture. I will try to put my wire across the stone into the ureter. Surface view, please.
I will try to put the wire now.
Goes down in the ureter.
In monoplanar technique, the best part is in 90% of the times you hit the posterior most aspect of the calyx so that the wire easily walks into the ureter. Once the wire walks into the ureter, your 90% of job is done.
Screw dilator. Gently with
once this is done, we try to dilate with single step Shah's dilator.
Using a 18 French Shah sheath.
So we are doing a single step dilatation here. So I will show you the puncture and the entry point.
This is the entry site. It's always good to be.
So here clearly the stone is seen.
This was
no bleeding at all. So it's a complete monoplanar technique puncture. What I have shown right now.
Inspected the system.
No need to move your Siams.
Detailed manner.
Again, it's an non-edited video of a monoplanar puncture technique. We'll show you.
A case of 72-year-old gentleman with his prior to surgery. Calyx very nicely.
So in this, it was narrow infundibulum, and it was not a targeting. It was a very minimal hydronephrosis was seen in this case.
Inferior calyx. So there is no movement of the Siams done in this technique.
We try to hit the cup of the calyx in monoplanar technique. The depth perception has been done. The skin to the calyx depth is calculated according to the stature of the patient, whether it is fatty or a very lean patient. According to that, we have to calculate the distance. So once we hit the desired calyx, we try to aspirate.
The lower
in the very first go, we are able to aspirate a very clear tap.
Itself, you can see clear aspirate coming from the puncture needle. Next.
So again, 30-degree orientation towards the skin surface is an important point. In monoplanar technique, always the puncture comes medially, then going laterally, and so the chances of hitting the posterior calyx are quite high in monoplanar technique. So here I am trying to put the wire. See, the wire has easily walked into the ureter because 90% of the monoplanar punctures are into the posterior aspect of a calyx. So there is no step in such punctures. There is no step in dilatation also. So you can easily dilate without injuring the renal tissue.
After this,
so I am doing a facial dilator here after placing the wire into the ureter.
Facial dilatation.
So I am placing a Shah's Ampla sheet.
We used an integrated 15 French super puff.
So there is no step at all. No step is noted here.
Direct our dilation.
You can easily enter the renal calyceal system.
Once this is done, we
this is the picture showing
this is the upper ureter, superior.
Another case showing semi-live video of monoplanar technique only. It's an RGP of a renal pelvic stone measuring 20 mm. In this case, again, you can see the cup of the calyx It is not obliterated, so very minimal hydronephrosis was there. We targeted the middle calyx to enter the system.
You can see I am doing this puncture in a 0-degree monoplanar technique. Where the CM is
So we have marked the site of the puncture, again oriented our needle 30 degrees to the skin surface of the patient.
Please. Shoot. Shoot. Shoot.
The depth has been calculated that around 2 to 3 centimeter I have to go in vertically and then orient towards the calyx, so that the cup of the calyx is been targeted. See, first a little bit vertical movement of the needle is been done. Once it reaches the calyx, we try jerky movements
try
to
to
feel
put
the
my
kidney.
wire in the ureter on the CM view, please.
It has gone inside. So it is a game of perception.
Walks into the ureter.
I will try to remove the stylet
You can
on the
see
very
there is
first
no
go. So
kink
it's
in
a
the wire
live
when I am
video
removing
showing
my needle.
clear aspirates from your monoplanar puncture. It is 30 degrees towards the skin surface and it is medial also. Let's see how the wire goes in. See, I have told you that the wire walks easily in the ureter when you are doing the case in a monoplanar technique, because 90% of the times you are hitting the posterior aspect of a calyx, which is directly orienting towards the renal pelvis, from which, so you can see there is no step to the wire at all. So we have dilated now. After dilatation also you can see there is hardly any bleeding. It's almost a clear tap. So once we go in, I will like to show how it looks from inside also.
These are the stones. See the pelvis.
This is the stone which was getting impacted. Now this is a very interesting case. I want to listen carefully. I was doing a PCNL and the CM got malfunctioned. The CM got stuck when the image was upside down and it was not getting repaired. We tried many things, but still the CM was on, but the image was not getting tilted upside down again. It was an difficult case, difficult orientation for a PCNL surgeon. How many times we should abort this case, but as I planned that we should do this case in a monoplanar technique through the middle calyx, because let the kidney upside down, the middle calyx will always remain as the middle calyx. It won't change its position whether the image is upside down or it is not in a correct orientation. So we plan to take a puncture in the middle calyx in a monoplanar technique, because here other techniques won't have been used because the orientation was in a very, it was not in a proper way. So we started doing, see the CM button has been malfunctioned. I cannot rotate the image.
I'm not able to rotate the button.
We tried everything, but the patient was there prone. We made the patient prone. We first tried the inferior calyx, but again orienting 30 degrees towards the skin surface, we tried to hit the middle calyx, because the middle calyceal orientation won't change even though the image is upside down. So this is a case where one has to learn how to puncture the kidney in monoplanar technique even though the image is upside down. So we were able to aspirate a clear fluid in the second go. See, I am trying to hit the kidney gently. I am pushing the kidney inside, and loss of resistance will give me a feeling that I am inside the kidney. So no need to move your CM, no need to change the angles.
Kidney, we have taken a puncture.
See, in the very second go, I was able to get
it's a
a clear
malfunctioning
tap.
of my CM, but as there is no service person available.
So then we tried to insert the wire which went in the superior calyx. It was a partial bifid system.
Upper calyx of the lower myocardium.
So now few demos of all the punctures right from superior to middle and lower. Let's see one by one. Small videos are there. It's a superior calyx puncture. See, I am coming supracostal in monoplanar technique, 0 degree technique. I am targeting my superior calyx again in 30 degrees towards the skin, analyzing the depth of the system.
We have taken.
We have oriented 30 degrees towards the superior calyx. I'm just moving my stylet.
Let's see.
You can see
clear fluid,
clear liquid coming out. All these punctures, all the monoplanar punctures are quite medially oriented.
We did the
But
puncture in
90% of the time you enter the system from the posterior aspect.
superior calyx puncture.
I have dilated the system with the Shah sheet.
Keeping the sheet
It's an 18 French dilatation.
of the clear
Even after dilatation, you can see that clear fluid is coming out. So there is no injury to the renal parenchyma. We have entered the system from the superior calyx. I am seeing the inferior calyx. I am coming out. This is the endo view of the tract after clearing the stone. This is the ureteric catheter. So from, even though the puncture is monoplanar, I am having a good maneuverability inside the kidney. The middle calyceal puncture. So this was the system. You can see this system. I have gently put some air pyelogram to target the posterior calyx in monoplanar technique.
Our plan will be again to do a monoplanar 0 degree puncture in this patient.
I am orienting my needle again. The Siam is fixed in 0 degree. I am not moving the Siam.
I will be targeting the middle calyx.
I am orienting the needle 30 degrees towards the skin again.
Anticipating the skin to calyx distance approximately around 1.5 to 2 centimeter
So
or 3
the distance
centimeter.
from the skin to the calyx has been calculated. It's an arbitrary distance. You have to feel the system.
Confirm whether we are in or not. I'll be going in the kidney through the posterior most aspect of the middle calyx. I'll be showing it once I enter the system. On the screen, please.
So I'm demonstrating a semi-live video now.
अब थोड़ा श्वास घेऊन रोखून धरा बस.
So the patient is in spinal anesthesia. I have asked to
targeted my needle
take a deep breath and hold the breath so that my
मी जेव्हा परत
puncture is
तेवढा परत श्वास घेऊन रोखून धरायचा. Shoot.
30 degree marking is done.
श्वास घ्या परत.
The patient is holding its breath, vertical movement, then towards the desired calyx.
घ्या परत श्वास सोडू नका. The patient.
So I am asking the patient to hold his breath. I am targeting the desired calyx
jerky movements
and with
going. घ्या श्वास घ्या बाबा सोडू नका.
Okay, fine. So the kidney is moving and we have
on the surface view, please. I am inside the kidney. There is.
See, the wire has walked into the ureter. So no resistance to the wire to go into the ureter has been
that the wire has walked into the.
Dilatation is also very easy part, as it's a very straight part towards the posterior calyx.
With a single step,
dilated with Shah sheet. I'm going inside the kidney. This is the tract, the lower pole, the lower calyx. You can see the lower calyx infundibulum. There was a stone there. So now puncture from the inferior calyx. See, the stone is lying. It's a very acute angle, acute to the pelvis, very acute angle, the completely occupying the lower pole. The stone is completely occupying the lower pole. It's very medial puncture we have to take, as the calyx was very acute to the ureter and the pelvis. So again, I am targeting this case in 0 degree monoplanar technique. See, I am moving the kidney gently. I am going towards the stone desired calyx. And once I reach, I can feel the stone here. I was able to feel the stone. And once the stone was felt, clear liquid is coming.
Clear water.
We removed our stylet and we tried to put the glide wires. So I am putting a glide wire. So as the stone was completely occupying the lower calyx, it was difficult to place a glide wire here, as there was no space left. But with some movements of the initial puncture needle, we could able to coil the wire and place it in the renal pelvis, and then it walked into the ureter.
So I try to put into the ureter.
So the added advantage here is that with the posterior calyx puncture, there is little space between the stone and the calyx from where you can park your wire into the ureter. So these are some anatomic variants I want to show, that even in the ectopic, this was an ectopic kidney having the renal size. We did this case again in monoplanar technique.
We chose prone PCNL injury measure of the sauce.
So through the sauce muscle we took the puncture. I will just show. I will just run this video.
Targeted
so this
in
was
a 0.
This was the RGP picture.
To see the air pyelogram.
We did an air pyelogram.
We then targeted the superior pole lateralmost calyx in a 0-degree monoplanar
through the sauce muscle
puncture.
To this system without USG guidance.
The puncture was very medial to the routine PCNLs what we do.
It was, see, the needle has almost gone inside completely, as it was a very low lying kidney.
In the very first go, we were able to aspirate clear fluid from the puncture.
And then we could dilate the system with Shah sheet. So what does our data say? We have done almost 3000 PCNLs with monoplanar technique and single step dilatation. Almost of those 1200 were staghorn stones. 45 had an abnormal anatomy like ectopic, horseshoe, anteriorly rotated kidneys. Multiple track dilatations were needed in almost 1800 patients. All were done in monoplanar technique. Only 2 patients needed blood transfusions. No incidence of bowel injury or other internal organ injuries. 1 patient had AV malformation, for which we had to do endocoiling. So there is no ideal way to do monoplanar punctures. Perception is what matters. One can see 4 or the other can see 3. Every case is different. One has to orient accordingly. But never forget the power of your mind, the power of imagination makes us infinite. Thank you.
Okay, Harshawardhan. That is a nice area of cases.
Sir, just a minute. Heavy rains are there. I will place a earphone, sir. Just a minute. I'm not able to listen you.
Oh, are you audible? Am I audible? Am I audible? Unmute.
Yes, sir.
Am I audible?
Yes, sir. Yes, sir.
Yeah. So it's a nice array of cases. I wanted to ask you some controversial questions.
Sir, 1 second. Sir, sorry. 1 minute, sir. 1 minute. Sorry. Loud sound is there, sir. 1 minute.
For the audience who are seeing, see what he's telling the technique is. What he is telling the technique is monoplanar. Whether it is completely can be done in all cases monoplanar or not. Whether we have to believe it in that, what is the advantage in monoplanar? Why can't you see another angle with limited C-arm or the controversy? Traditionally, triangulation technique and bullseye techniques, you have 0 degree and 30 degree, which is scientific logical. In monoplanar, you see the movement of the calyx, top of the calyx. Sometimes your needle goes little medially also. If you are not getting urine in monoplanar, what will you do? This is my first question I wanted to ask. What is the options? See, to my memory, monoplanar is ultrasound guided puncture, because 3-dimensionally you can see the end of the calyx and your needle goes right into it, and there is no need to show another plane because it has 2 eyes. Harshawardhan, are you able to listen?
Sir, yes, yes, I am now able to listen to you, and that's
Yeah.
it. Thank you, sir.
See, Harshawardhan, be open mind in my questions.
Yes, sir.
My first question is, there is an anterior calyx and middle calyx. In the middle calyx, anterior and posterior are there.
Yes, sir.
You are in inferior calyx, overlapping of the posterior calyx with the long anterior calyx is present.
Yes,
How
sir.
do you assess in one angle whether you are puncturing correct calyx or not? Apart from air pyelogram, do you use any other method? For example, monoplanar technique, you are telling I will go and I will hit the calyx. How will you identify the posterior calyx first of all?
Yes, sir.
That is my first question.
Yes, sir. In
How will you say that the calyx which you are aiming is posterior or anterior? If they are very close, your
right.
little anterior, little posterior will be there. How will you
Yes,
assess yourself which is anterior, which is posterior
definitely.
before you
Definitely.
puncture?
Yes, sir. Sir, am I audible?
Yes.
Okay, fine. Sir, a very nice question. First of all, I would like to say that we have all learned in PCNL that it is the posterior calyx in the prone PCNL that we have to hit, because it is the most superficial calyx in a prone position. And in all the videos, I have shown that in doing monoplanar technique, I am trying to hit the posterior calyx so that the wire goes easily inside. Now the question to you is, I always or many times I use an air pyelogram, but without doing an air pyelogram also we can assess. If there is an overlap, there is some difference in the anterior calyx when the patient is in the prone position, and when we do RGP, anterior calyx are always densely opacified due to the contrast, rather than the posterior calyx is a faint opacity always seen. That is the difference. And also, if you look carefully in all the RGPs, what we do, there is a slight difference of the rim. The anterior calyx rim is more lateral and the posterior calyx rim is more medial. So this is the differentiating point without doing an air pyelogram.
Okay. A theoretical question I am asking. You have
Yes,
tried 5 times, 10 times in a malrotated kidney or in ectopic kidney or in some other kidney which is previously operated. You failed in a monoplanar. You assessed anterior, posterior, posterior, anterior. Especially in children, it will be too superficial. If you are repeatedly failing, what comes in your mind? What will you do? Do you follow triangulation or bullseye, or you keep trying in different depths blindly?
many times, 90% of the times, we are able to successfully puncture in monoplanar technique. This was the same question asked in the live conference also by a delegate,
Hello.
that whether you always follow. I am not rigid, sir. No surgeon should be rigid with his techniques that I will do only this, I will do only that. You, when you are doing a PCNL, you have to give justice to the patient by clearing the stone, and you have to be flexible, that any technique you should be knowing all the techniques. You practice one technique, but you should be thorough with all the techniques. If one technique is not hitting, is not doing well, you have to switch.
I am asking which is your
Yes, sir.
favorite, which is your
I'm not
favorite in difficult cases, triangulation or bullseye, apart from monoplanar?
a bullseye. Bullseye. There is no other technique apart from monoplanar, because in bullseye, it's quite similar to the monoplanar technique. Only no very mathematical calculations are there. Best technique after monoplanar, I guess I use many times, is bullseye technique.
And what about the, how will you judge the entry point distance from the calyx end? Is there any criteria or rough judgment? Some people say below the 12th rib, some people say 4-finger bridge, some people say the posterior axillary line, some people say mid scapular line. How do you entry point? How do you decide in any technique?
Yes.
Forget about monoplanar. Entry point, what is, it's only your intuition, like you said, you think with your brain and go ahead.
Yes, sir. We need to think with the brain and go ahead, because God has created
human being, a different human being. No two kidneys are similar. Like no two faces are similar in the world. No two kidneys are similar in the world. Everything has to be on table itself. It's a judgment. That's why that the outset I have told that PCNL is a game of judgment. You cannot make rules of PCNL that yes, this should be the entry point, this should be the exit point. Every kidney is different according to the fat thickness, according to the skin to the calyx distance, according to the orientation of the calyces on the RGP. You have to decide your entry point. Only thing is try to enter from the posterior most aspect of the calyx so that things will be easy for you in prone PCNL. That should be your, and the distance skin to calyx distance should be less so that your scope movement doesn't have a torque for the movement of the inside the kidney.
What about the horseshoe kidney when anterior rotation of the kidney has happened? Do you have any points in monoplanar technique? Because all the calyces are turned posterior, and they are medially located and they are down. So do you want to address that? You might have done horseshoe kidneys. What is your take on horseshoe kidney?
Whenever we have a horseshoe kidney, in horseshoe kidney, it is an anteriorly rotated calyx. All the calyces are facing posteriorly. For monoplanar technique, it becomes more easy to operate over such cases when the kidney is anteriorly rotated because all the calyces are facing medially and posteriorly. So it is very easy for us to see because then it is getting oriented directly in the CM. It's like doing a bullseye. In monoplanar technique, it is like doing a bullseye when you are rotating the CM towards you in a normal variant. But in horseshoe, you are directly seeing the posterior most aspect of the calyx. You have to just come vertically, medially, and hit the desired calyx. Only thing in monoplanar technique, it looks to be more vertical punctures than in standard techniques, but it doesn't matter at all. In horseshoe kidney, it is more easy to puncture horseshoe kidney in monoplanar technique.
What about the puncture of the anterior calyceal stone if it is alone and it is not amenable to the RIRS? What is your take? Anterior calyceal stone, for example, 1.2 centimeter anterior calyceal stone not amenable to RIRS. You have made it prone. If the stone is not radio-opaque and you have dilated, two contrast filled middle calyces are seen. Now, how do you approach in monoplanar technique?
Right, sir. Sir, in such cases, when there is an anterior calyceal stone, every anterior calyx is going to have a posterior calyx. It cannot be that only anterior calyx is there. In monoplanar technique, we try to hit the posterior calyx, and from the posterior calyx infundibulum of the anterior calyx, we try to use in such situation mini PCNL because there should be no injury to the infundibulum of the calyx. And in such cases, when you are telling that it is not amenable to RIRS, it's an impacted anterior calyceal stone. So in such cases, I do puncture the posterior calyx, try to enter the desired calyx where the stone is lying with a small scope, try to juggle the stone out with vibrations of a holmium laser or using a forceps, try to take out the stone from the calyx, place it in the renal pelvis and then finish off the case.
Why not, for example, if it is a V-shaped of infundibulum, both the anterior and posterior are separated by V-shape, why don't you use the same technique to puncture anterior also? You assess the depth, you go and puncture. There is nothing in your technique, there is nothing.
In the last case, in the inferior calyceal stone, it was an impacted stone. It was completely impacted stone in the anterior calyx.
So, you can puncture, no?
Yeah, we can directly puncture the anterior calyx. There is no, and in monoplanar technique, one biggest advantage is
in monoplanar, what is that you assess that, then if it is moving, then directly you will hit the calyx which is having stone.
Yes, sir. Yes, sir. Yes, sir. Definitely.
There is no problem.
Also in monoplanar technique, as the punctures are medial, you try to avoid the bowel injuries also. Means there is no single bowel injury because I have already told that in monoplanar punctures they are more medial towards than the standard punctures. So the more medial you go, the less bowel injury will be there.
Okay. Last couple of questions. And for example, if monoplanar technique you wanted to teach the juniors, how will you teach? Because it's your brain, it's your hands, your calculation. Okay, you are good, you are very good, you are extremely good. You can puncture, you can take it out. You say that medial puncture, you say that some contrast patchy difference will be there. You say that the angle will be there. How do you teach? How do you teach monoplanar to a junior?
Yes, sir.
What
Teaching
will you tell?
monoplanar.
For example, one fellow will join with you. You're doing daily, what you will doing. Stone will come, he will clap. And when he takes, he will go in other angle and blood comes. You can't say you go anterior or you go posterior, you go deep. Then you have to take over. How do you teach a junior monoplanar technique?
Yes, sir.
I
Right
already
now,
told you are close friend. That's why I'm taking a little bit of budge on this.
yes, sir. Sir, actually, nowadays with me, I'm having a junior. Dr. Sanket is there. He's trying to learn the PCNL technique, and I'm happy that it is now. The last time I told you that it is not reproducible, but looking at Dr. Sanket is doing an excellent job right now. I'm able to teach him in two aspects, sir. First, I taught him to orient the needle, only skin surface needle orientation, and to calculate the depth of the calyx. After that, in second stage, I taught him to how you feel a calyx. Slowly, jerky movements should be done without moving the C-arm. And now he is able to slowly and steadily, after 3 months, he is able to hit the desired calyx. So it is going to take time because there are no mathematical calculations as in bullseye and triangulation. But if one can learn this technique in over a period of 2 to 3 months, it is very easy technique to learn and clear all the stones. It's not that hard. But
Last
definitely,
question.
definitely bookish. There is no reproducibility, as you always tell me.
Yeah. There is some hitch in this.
Yes.
You only can do it. That is the thing.
Yes.
I have seen
Yes.
subnits are also doing many of the times in single plane. But we it's see forever it is don't think we are debating. Forever it will have discussion.
Yes,
Very few surgeons they hit in one angle. They have the depth, but juniors who doesn't have great perception of depth, they can rotate and see. Do you agree or not? They can rotate and see.
Yeah, definitely, sir. See, first we have to learn how the kidney feels, how one has to enter, what are the dilatation techniques rather than puncturing a kidney and not able to dilate, or how you have to tackle with the steps in a dilatation. Sometimes we do have steps. The wire doesn't go straight into the renal pelvis. There is a step. So, with the avoiding the step, clearing the step, because if you try to dilate, it is going to tear the kidney. It is going to perforate the kidney. So all these things should be learned gently. There should be a good training protocols, good designs of training PCNL should be done. And once it is done, then slowly and steadily he can master the art of monoplanar technique.
One question from the audience: that do you use bolsters when you are using this technique?
So I don't find any use of boosters in this technique. Firstly and foremostly, because once we do boosters, there is no counter traction to the kidney. The kidney is lying freely, hanging freely when we put boosters in the hip region and in the chest region. So the kidney tries to float. Once the patient is made prone, there is a counter traction from the table towards the kidney, and the kidney is pushed towards you. In prone PCNL, we want the kidney towards us and not away from us. And when we are trying to dilate the things, there should be a counter force from the opposite side so that the kidney doesn't move. It should not be a floppy kidney. So I don't use any book.
Even I do not use in prone PCNL bolster. I also feel that whatever Harshawardhan told is correct. There should be counter pressure and kidney has to be pushed by the table through the abdomen anteriorly. In case anesthetist ask for it in a very obese patient, too obese, if they are uncomfortable, then only I don't think I have used, and our anesthetists are also used and they do not complain. And the last question, Harshawardhan, When you got training in KM, your bosses might have done PCNL, and you might have seen some other colleagues like Yogesh and all doing PCNL. Have they done monoplanar? For example, Madam Patwalkar sir, Madam, have they done PCNL in monoplanar, or you are only developed this technique?
No, sir. In KM, majority of the KM first out students are doing monoplanar technique, and they are very good in PCNL because we had a very huge stone load at KM. We were fortunate enough, with the grace of God, that we were able to do our super specialty at KM hospital, and it was a free hand in KM. We have to do all the PCNL on our own right from second year. So we could learn by mistakes, by seniors, by all good teachers, by holding our hand in hand. They taught us to do PCNL. But yes, definitely there were some professors who used to do bullseye. Some were used to do triangulation technique, like Patwardhan madam used to do in triangulation or bullseye. Ismail sir used to do in monoplanar technique. With all this combination, permutation and combination, we could judge our own self that yes, this is one of the best techniques, and we could mastery in one of the techniques after seeing many techniques.
Okay. So thank you very much for sharing your information. So dear Pure Urology viewers,
Thank you, sir.
the one thing which I agree is PCNL is whatever said and done, it is semi-blind procedure unless you use ultrasound. So if ultrasound used, that is a totally different issue. If CM is used, intrinsic understanding of the depth, perception and the angle of entry and the entry point is a huge discussion. Years together, for last 30 years, we are discussing, we are following, some do well, some learn well, some will struggle. But ultimately, if you understand the anatomy, if you stay to the posterior calyx in supine, exactly opposite may happen in supine. In posterior calyx in prone is always better because it is superficial. If it is superficial, if it is lateral, it is better. Superficial is given more priority than lateral. So in the entire discussion, if you can enter the kidney superficially, chances of the vessel coming in your area is very less. The tract is less, and the ability to move in the kidney without torque is good. So idea of this presentation he made, what I understood is posterior superficial calyx, the most superficial you reach and get the urine with your needle movement and loss of resistance, then you are very safe. Some of his needles are gone little beyond the calyx, still he is superficial. He is in the superficial calyx, that's why he can look down and move all around. That is what I understood with this presentation. Definitely it is a skill. Scientifically, in future, you will get all the questions which I asked again and again. He has to defend that. But technically, it is a good understanding of the anatomy, RGP, filling of the contrast, air pilogram, contrast assessment, the density of the contrast assessment. He has mentioned everything very well. So I thank Harshawardhan, and definitely I have seen live surgery by him. He applies this principle very correctly, and most of the times bloodless urine comes. That is appreciated. As long as the patient is getting that benefit of entering without blood into the proper posterior calyx, you are successful on that day. So that technique has to be assessed and learned if possible in practice. Thank you very much, Harshawardhan, for your presentation.